we have a test coming up on some drugs that are used in the heart, and the main problem seems to be confusion about the difference between heart failure and angina. Now, once you have experience with patients and you start taking pathophysiology courses, you'll realize that these two conditions are totally different. Okay? Angina is sort of what happens before you have your heart attack. Heart failure is what you have after your heart attack. Obviously, I always ask you guys critical thinking questions on tests, and I'm going to ask you to figure out what's going to happen in the heart in a patient with angina or heart failure with some combination of drugs you haven't seen before. So there's no way to sort of just memorize every combination. The way you have to deal with it is to just know the physiology. So I'm going to go over the physiology, and then I'll give you an example problem that was on a test a couple years ago, so that you have sort of see what I'm sort of driving at, right? Okay. All right, let's give it a shot. All right, so we don't know that many drug classes that affect blood pressure at this point. It's a half dozen or something. But in terms of the physiologic processes, we've only really talked about adrenergic, cholinergic, angiotensin, aldosterone, ADH, and that's about it, okay? So you have to know those different receptors, where they are, and what they do when they bind their ligand, and then you can figure out any of these problems. So a couple of things just to review, right? So we have alpha-1 adrenergic, right? So that's norepinephrine or epinephrine is binding those, okay? Which causes vasoconstriction. When you're first learning angina and heart failure, I would just say, remember that alpha-1 adrenergic mostly constricts arteries. I think that's just an easier way to think about it. Okay, then we have beta-1 adrenergic, right? So norepinephrine, epinephrine, binding those receptors. And those receptors, adrenergic receptors, are found in the heart, right? Where they cause an increase in heart rate. And the other place is the kidney, right? They increase the release of renin. Okay. Let me just remind you also, there's cholinergic receptors, right? And cholinergic receptors, particularly muscarinic ones, cause a decrease in the heart rate by which nerve? Yes, the vagus nerve. There's also what was covered, I think, in the last test, or possibly the first one, I can't remember, was the idea of your body's normal reaction. Even if there's no drugs in your body does react to changes in blood pressure, because you have to keep your blood pressure, you have to keep getting oxygen and glucose through your bloodstream, and so your body has ways of very quickly reacting to changes in blood pressure. So one of them is the vagus nerve, right? So if you have an increase in blood pressure, the normal, okay, I'm going to write normal situation is that if you have an increase in blood pressure, the vagus nerve, working through acetylcholine and muscarinic receptors, right, decrease heart rate. And if you have a drop in blood pressure, the sympathetic nerves, working via epinephrine and norepinephrine, and beta-1 receptors, increase heart rate. And that there's a special term for the reaction of your body to a drop in blood pressure in terms of heart rate, which is reflex tachycardia. Make sure you know that phrase and that you will recognize it on a test. Hint, hint. Okay. So reflex means it's a reflex of the body. Tachy means fast. Cardia is heart. So fast heart. Okay. So those are some receptors we know about. So we should be able to predict what will happen if we give a patient a cholinergic agonist or an antagonist, or a sympathetic agonist or an antagonist. Okay. Now we also talked about renin, and that's hopefully some review for most of you guys from A&P. Okay, so here's my little rendition of a kidney. Oh, this is a sad-looking kidney. That's okay. The kidney releases renin in response to two things. Either a drop in blood pressure as measured by the kidneys, because they have that juxtaglomerular apparatus, and then also sympathetic output increases renin through beta-1 receptors. So what does renin do? Well, renin, stimulates the release of angiotensin and aldosterone. So how does it do that? You take angiotensin, that goes off to the lungs, which I will also draw poorly here, okay, where there's an enzyme called angiotensin converting enzyme, which then converts that into the active form of angiotensin, which is, I think, angiotensin 2. I don't care what it's named, I just want it to work. Okay, then angiotensin can stimulate a couple of things to happen. It can either cause direct vasoconstriction, which is going to have most effect in the arteries. I just think of it that way. I believe angiotensin and adrenergic can go to the veins as well, but let's just stick with arteries. And then you also have angiotensin, which stimulates aldosterone, and to an extent ADH, which both have the effect of increasing sodium and water retention, which means you have increased fluid. All right. Now, increased fluid is always going to have most effect on the veins, right? Because you have arteries, which are like these big muscular things that can constrict and dilate very quickly. And then veins, which are kind of these big floppy things, which can stretch and stretch and stretch if you put more and more fluid in your bloodstream. That's why varicose veins, they start out as little and they get bigger and bigger and bigger because veins can stretch because they're kind of floppy. Okay, now one last review just to be sure everyone's on the same page. Angiotensin, how does that act? How does activated angiotensin act? How does it increase aldosterone? Because it doesn't just, magically wave a wand. There has to be something at the cellular level that is going to increase aldosterone. The way it works is through angiotensin receptors. Yay! How does it increase vasoconstriction in the blood vessels of the body? Through angiotensin receptors. Okay, so activated angiotensin binds its own receptor on arteries to cause vasoconstriction. That's going to be a different receptor than the alpha-1 adrenergic receptors. Okay, so you have two processes causing vasoconstriction. Again, your body is most interested in keeping your blood pressure high. It's really, vagus nerve is pretty much the only way to, get your blood pressure down in a jiffy. Because you can't be low blood pressure for even a moment because lions eat you, right? Okay. All right. What about aldosterone? How does that work? How does that cause the kidney to retain fluid through sodium retention? Well, it's through aldosterone receptors, which is getting written very small, but that's what I'm trying to write there. And ADH, how does it work? Through ADH receptors, okay? All right. So if I were to say, I'm going to give an aldosterone agonist, then you have to think, well, where's the aldosterone receptor? Well, it's on this step of the process. So if I give an aldosterone agonist, it's going to act like the natural hormone, because this whole thing this is the natural situation. And then that'll cause increased sodium and water retention. So you could give a patient who maybe had chronic low blood pressure an aldosterone agonist. Okay, and if I want to give angiotensin agonist, well then I know angiotensin, if it's an agonist, it's going to bind these receptors, yeah, and then cause vasoconstriction and fluid retention. Okay. One last thing, and then we'll move on to a sample problem. There's two ways you can block angiotensin's effect. I really wish I had another color pencil, but oh well. To block angiotensin's effect. One is you can block it from being formed, okay, by blocking the action of the enzyme that activates it. All right, so that's indirect acting, right, because it's doing it by glomming onto an enzyme, not by binding a receptor. Okay, and the example that we gave were named ACE inhibitors, which, yay, it's actually named for what it does. That's good. The other thing you can do is give direct-acting angiotensin blockers, right? And a blocker is the same as antagonist, right? So it does the opposite of the natural ligand. So a direct blocker, or antagonist, will bind the angiotensin receptor. Right? Which is going to be here and here. Okay. And you might say, well, it's the same thing. Because you might say, well, if I'm if I'm keeping the angiotensin from being made, or I'm keeping it from binding its receptor, that you should have the exact same effects. But you don't, because while ACE is hanging out around in the lungs, it actually has some other things that it does. It's sort of a multitasking kind of enzyme. And one of the things it does is it has effects on the levels of bradykinin in lungs. And when you give an inhibitor to that ACE enzyme, you end up with irritation of the lungs. So patients who are on ACE inhibitors get a dry cough because their lungs are irritated. And it's when I say dry, I mean they're not coughing up green, nasty stuff, right? And it's just because the lungs are irritated. And it's not like it's a fair number of patients get it. I read in one article it was up to 30% of patients who are on ACE inhibitors get the cough, which is a huge deal. I mean, you don't want to walk around coughing all the time, and also you can't sleep, and people think you're sick and won't come near you and be your friend. All right, so this was the older drug, the ACE inhibitor. The newer drug is this direct-acting blocker, and the direct-acting blocker, you don't get that coughing problem because it's binding the receptors, which is sort of farther downstream on the process, and you're not affecting that enzyme, which has other things to do. Okay, all right, so let's talk about angina and heart failure. So we have angina, oops, let's write it where you can see it, and heart failure, okay? What is the cause of angina? And we're going to make this left ventricular heart failure. Okay, what is the cause of angina? It's crappy blood vessels, right? Narrow, let's just say narrow. Okay. Narrow blood vessels. Oh, I'm not even going to write that. Let's try again. The cause of angina is narrow coronary arteries. Okay. In the cases we're talking about, the problem with an angina patient is that they have narrow coronary arteries. That's the problem. And because they have narrow coronary arteries, the heart muscle itself doesn't get enough. Because the coronary arteries, which are the arteries that serve the actual muscle of the heart itself, not anywhere else in the body, just in the heart, if those get narrow, then the problem, the thing that kills a patient, is that the heart muscle doesn't get enough blood, right? And and it needs the blood in order to have enough oxygen, right? If you have a coronary artery which is totally blocked, then the heart muscle is getting zero blood, and it's getting zero oxygen, and it dies. And that's a myocardial infarction or heart attack. Right? So that's really bad. In an angina situation, the coronary arteries are not blocked yet, but they are very thin. So that means that whenever the patient tries to work their heart muscle a little faster, it just can't get enough oxygen. And so they get chest pain. Angina means pain, right? So that's the way your body tells you that it's having a problem, is that you get pain. I mean, there's some reason that people have pain, evolutionarily speaking, and it's to warn you that you're being injured in some way. Okay, so that's the problem with angina. Now, in left ventricular heart failure, the problem is you have a weak heart. That's it. You have a weak muscle of the heart. All right, and in our case, it's that your left ventricle is weak. All right, now make sure you have it very straight in your head, the difference between a weak muscle, okay, and a narrow artery. I think what happens is you start studying this stuff and you're still thinking in civilian terms. You're not thinking in healthcare professional terms. So when you think heart attack, that's sort of in your head just because you're a human and you live in a society where people say heart attack all the time. It's not clear in your head what heart attack means because civilians use that phrase sort of to mean anything where your heart has a problem. But in the medical world, heart attack or myocardial infarction specifically means that the heart muscle gets no oxygen and dies. Okay? The heart failure we're talking about, left ventricular heart failure, specifically means that there's a part of the heart that is a scar, because we're presuming that the patient had a heart attack and survived. So it's not a huge scar. Their heart can still kind of work, but it's weaker. Okay, so heart failure is a weak muscle of the heart itself. Okay? Angina is a problem with specifically the coronary arteries. That's why there's only a few drugs we can use for angina, because there's only certain situations where the coronary arteries specifically dilate in terms of drugs. Okay, so now, all right, so that's the problem. Okay, so what kills the patient, right? What kills the patient? Because that's, first, do no harm. And the other reason we do our healthcare is because we want to keep people from dying, because when you die, it's all very sad, right? So we don't want to kill any patients, right? But what kills the patient from angina is the progression to a heart attack, right? So a myocardial infarction is what kills the patient, and that's in healthcare words, heart attack, myocardial infarction. The patient can die from two possibilities. One is, right, because the question is you're not getting enough blood to the muscle. So either you get a total blockage of vessels, I should write vessels because you guys will think I mean a vein, or the heart rate is too fast. Okay. In a heart failure patient, a left ventricular heart failure patient, what kills the patient is backup of fluid into the lungs. Okay? We call it, fancy words are pulmonary edema. But it's basically drowning in your own juices. Okay. So you can see, hopefully now I'm slowly convincing you that these are two very different problems. Angina is specifically, the problem has to do with the heart itself and the blood vessels that go to the heart muscle. Heart failure, the problem is that the muscle's just weak and can't pump against it can't pump blood around your body. That's a problem. So if you see a question on a test, and then later in life you'll see patients, if you see a patient with left ventricular heart failure, you should automatically be thinking the problem is a weak muscle, the thing that will kill them is pulmonary edema, right? So if you have a weak heart, what's going to kill you is not a heart attack, because a heart attack specifically refers to the coronary arteries getting blocked or the heart rate going too fast. That would be a myocardial infarction or heart attack, right? You have to understand exactly what will kill the patient so that you know how to treat them to prevent that from happening, because I would hope you don't want your patients to die. Okay, so goals of treatment, okay? In angina, the goal is reduce the heart rate, prevent clots, because you don't want the blockage, and dilate coronaries, the coronary vessels. Okay? Those are what you want to do. If you understand this, then you almost don't even have to memorize it. It just should make sense. In left ventricular heart failure, however, because the problem is the heart is weak and having to pump blood all around your body, and if it can't pump it all around your body, the fluid backs up in your lungs, what you're trying to do is reduce afterload. Please see my previous videos for what that means if you can't remember. The other goal is you want to reduce preload. And you want to reduce total volume of blood, right? Which is actually a subset of preload, okay? And then you also want to try to make the heart stronger, if you can. Okay? Cool. All right, let's do a sample problem, okay? So say I'm working in a hospital and I'm taking care of two patients. They're roommates. The first person has angina. Let's say it's Mrs. Smith. All right. And you know that she has angina because it says so on her chart, and everyone tells you that that's her problem. And then her roommate, Mrs. Jones, all right, she has left ventricular heart failure. Okay, let's say it's you have a new intern. It's their first day as a doctor. And you're having to take care of these patients with the new doctor taking care. And the new doctor gives you tells you to give them both IV beta-1 agonist, just any old beta-1 agonist, okay? So you give them both a beta-1 agonist, and you are feeling quite happy, and then you need to go check on some other patients. You come back, they're both dead. Oh, what happened? Okay? So you might say, oh, the beta-1 agonist must have given them both heart attacks. But no, because the heart failure patient does not get a heart attack. That's not what kills her. Okay, so let's figure it out. Okay, well, a beta-1 agonist, the goals of treating angina are going to be decrease heart rate, prevent clots, dilate coronary arteries. Okay, so a beta-1 agonist we know will increase heart rate. right? Because it binds beta-1 receptors on the heart and increases heart rate. Well, that's the opposite of good, right? So we want to decrease the heart rate, because if you increase the heart rate, then she has an MI. Oh, bleh. Well, that's not good. Now everyone is sad. Okay, but that's what kills Mrs. Smith. The specific mechanism is that you've given a beta-1 agonist, a beta-1 adrenergic agonist. It's going to only bind beta-1 adrenergic receptors, right? And those are only found in the heart and the kidneys, and that's going to kill her, is the MI. Now, what about the patient with heart failure? Okay, well, let's think, again, what are the actions of beta-1? All right, so it can increase heart rate, all right? And it also has effect on the kidney, yeah? And in the kidney, normally you have an increase in angiotensin, and you normally have vasoconstriction and fluid retention, okay? If you're using an agonist, right? So the beta-1 agonist acts in the kidney to increase aldosterone, ADH, that kind of stuff, which increases volume, which increases preload. Oh no, all right, that's no good. The other thing that the angiotensin, I should probably put angiotensin in here. It's just such a long word, I hate writing it. Okay, so the angiotensin also will directly bind blood vessels, okay, and cause vasoconstriction. Vasoconstriction, let's say, in the arteries, and so that increases afterload. Okay. Well, that's the opposite of good. What you want, this is the good, the goals, right? You want to decrease afterload, and you just increase their afterload this way. You want to decrease preload and blood volume, but you just increase the volume and preload. So doing those, increasing afterload, increasing preload, is what's going to kill Mrs. Jones. And she's going to die of pulmonary edema. Now, you could, in a real-world situation, you could make all sorts of arguments and say, well, the increase in heart rate really wasn't that good for her. You could say, okay, all right, okay. But that's not what killed her. The thing that killed her was the vasoconstriction of the arteries, which increased afterload, and the increase in blood volume, which increased preload. Okay? So when you're looking at cases on a test or in a homework assignment, if I tell you this patient has angina or this patient has heart failure, first of all, I'll never give you a patient that has both. You can get plenty of that once you see real patients. Let's keep it separate, okay? So if you see a patient with angina, you say, okay, angina, they die from myocardial infarction, and either the blood vessels are too narrow or blocked, or the heart rate's too fast. So that's what I have to look for, and that's what I have to figure out, okay? Heart failure patient, we're only talking about left ventricular heart failure, so problem is the heart's muscle is weak. What kills them is pulmonary edema, and so I have to try to decrease afterload, preload, blood volume, which is part of preload, and make the heart stronger. If I don't do those things, if the opposite is happening, then that will kill the patient because they'll have pulmonary edema. Now, lastly, one last thing is just review of what are the kind of drugs that we use, right, for these different conditions. For angina, to prevent clots, we use blood thinners, right, anticoagulants, so aspirin, something like that. To dilate coronary vessels, what do we use? We use nitroglycerin, right, nitrates or nitro paste, and calcium channel blockers. And the easiest way to think about it is just to think that nitroglycerin and calcium channel blockers are really the only drugs that are really good for dilating coronary vessels, because those vessels are sort of a different situation than the blood vessels in the rest of your body, okay? So that's what you're using nitroglycerin and calcium channel blockers for. And then to decrease heart rate, our buddy, the beta-1 blocker, all right? Which could be I think the only two I've asked you to learn is atenolol and propranolol. Both of those block or antagonize beta-1 receptors, so they'll both decrease heart rate. So these drugs are good, other drugs might not be so good. To decrease afterload, we got to do something about vasoconstriction, right? Now, ACE inhibitors can decrease afterload and preload because they affect vasoconstriction and fluid retention. Okay, so drugs you use for heart failure. ACE inhibitors, you use diuretics to get rid of that blood volume, right? And yeah, afterload and preload, ACE inhibitors. The only weird drug is, drugs like carvedilol, which are these very strange acting drugs that change the muscle of the heart itself at the cellular level to make the heart stronger. Then, we talked about artery dilators that you can use to reduce afterload. We can talk about vein dilators that reduce preload. That's cool too. And then to make the heart stronger, we specifically talked about digoxin. Right? Digoxin works to make the heart stronger because it gives you more calcium inside each cell, which makes the muscle contraction better. And then, of course, you would not want to give a calcium channel blocker to a patient with heart failure because that's going to be the opposite of good, right? So, yeah. Okay. All right. I hope that helps. If you're studying and you're worried or afraid, just call me, text me. I turn off my phone when I'm asleep. So I've had people call me at 2 in the morning. If I'm awake, I'll answer the phone. So just give me a call or a text or even an email if you're having any, if you're terribly stuck and you need help or guidance. Okay.